Welcome everyone to this special meeting of the U.S. Action Working Group. My name is Charmian Proskauer and I serve as chair of the U.S. Action Working Group. We're delighted to have Dr. Leonard Jason as our featured speaker today. But first, a few words about the U.S. Action Working Group. Started in 2015, the USAWG is an informally organized group of over 100 individual ME/CFS advocates and representatives of ME/CFS organizations from all across the United States. We share information with each other in monthly meetings and on our listserv. We serve as a resource and a support for one another in our advocacy and educational work that benefits the ME/CFS community. We invite you to learn more about our group at usawg.wordpress.com. Before we introduce our speaker, a bit of housekeeping. Everyone was muted when joining the meeting, and we ask you to stay muted to minimize background noise. Please type your comments and questions into the chat. During the Q&A, we will answer as many of them as we can. The meeting is being recorded, but the recording will only show designated speakers and the slides. We'll be posting the recording within a few days, and we will send the link to all of you. We also remind you that we cannot answer personal medical questions, and anything said here does not constitute medical advice. Finally, the ideas expressed here are the views of the speakers and do not represent the position of the U.S. Action Working Group. Now I would like to introduce Art Murin, who will introduce our speaker.
Okay. Thank you, Charmian. Okay, I'm here to introduce somebody who to most of you needs no introduction, Dr. Leonard Jason, Professor of Psychology and Director of the Center for Community Research at Depaul University. Dr. Jason has had a long and distinguished career, having over 1,000 citations to his credit and having served on numerous panels, advisory committees, and editorial boards. Dr. Jason is known for his community-based epidemiological studies involving ME/CFS, which have been viewed as the gold standard. I have worked with Dr. Jason for over 5 years and have been continually impressed by his acuity and insight. Today, Dr. Jason will be talking about the importance of case definitions, which has been a chronic issue with ME/CFS and is already having a bearing on long COVID. Thank you.
Thank you, Art, and thank you all the guests to this broadcast. I'd like to start out with a couple comments, but maybe we could go to my first slide. That would be great. And there are currently multiple definitions or frameworks proposed to study PASC, and they vary by types of symptoms, by the timing of the symptoms, and even the name to call the syndrome. I think there's a need to reach a consensus on a case definition for PASC. The experience that we have had in the ME/CFS field for the last 3.5 decades, I think could be useful and brought to bear with some of the same issues that are occurring with PASC. In this talk, I use the term PASC and long COVID as synonymous, but I recognize the term long COVID has been used sometimes to refer to those without organ damage. In addition, there will be many with PASC who will not be diagnosed with either ME or CFS as individuals with post-ventilator syndromes or obvious damage to lungs, heart, organs, brain will not be included. In addition, some post-COVID symptoms like hair loss are not experienced by patients with ME or CFS. I think it's also important to recognize we need to fund research in PASC as well as ME and CFS. And I think it would be a mistake only to fund research with PASC, which does have a clear precipitating event. I think it's possible that we might find that the cause of long COVID at the molecular level, like persistence of the SARS-CoV virus or its proteins, might not be what is causing ME and CFS, despite overlapping symptoms. So with those preliminary comments, we'll go on with my talk, implications of ME and CFS, case definitions for long COVID. Next slide. The task that we have as scientists, as well as people who work closely with patient organizations, as well as the federal government, is to, in a sense, develop reliable and valid case definitions in any area, whether it's cancer or whether it's AIDS, it doesn't matter. It's very important. And that means we have to decide on what symptoms are contained in a case definition. That's often the first task that we need to decide on, not an easy one. The second one is we have to use valid instruments to reliably assess agreed upon symptoms from the first task. And third, we need to have thresholds regarding whether or not a particular symptom is severe and frequent enough to meet criteria. Those three domains we're going to cover during this talk, and I hope to convince you that these things are necessary not only for the ME/CFS field, but also for PASC. Next slide. In a sense, this is a house of cards, and the bottom row is really the case definition. And that bottom row has to be sturdy for the other cards to be built on top of it. And the other cards that are built on top of it have things to do with etiology, pathophysiology, treatment. In a sense, if one can't reliably make a decision about who has or doesn't have a particular illness or disease, everything else on top of that becomes shaky. Next slide. So let's first talk about the core symptoms. For a long time, it was really unclear what symptoms were to be focused on in ME/CFS. And I'll review some of that controversy today for those of you who aren't as familiar with it. Case definitions and basic research helped identify key symptoms over actually a 35-year period. And with PASC, I think we're confronting similar issues in deciding what symptoms to include. Next slide. So let's start with Ramsey's Myalgia Encephalitis. As many of you know, this term occurred early in the, even about 20 years before this particular important publication of Ramsey. And basically, they identified common symptoms. But what I put in yellow is fatigue after minimal exertion. That's not daily fatigue, and delayed recovery of muscle power after exertion ends. They also indicated a couple other areas, in particular, the involvement of central nervous system and circulatory impairment. These symptoms later got operationalized and called the London criteria by several different groups, including in Great Britain, Goodsmith and others. And certainly many of you are aware of some of these individuals. Our group at DePaul University made 3 different efforts to operationalize these criteria. And we found, very interesting, that it did identify a much smaller group than other case definitions, and a group that basically had more symptoms as well as impairment. So I think there was a lot of merit to what Ramsey did, over 35 years ago. Next slide. So in 1988, the same year that Ramsey produced that monograph, the CDC introduced the term CFS for chronic fatigue syndrome. And as you probably know, there's a number of reactions to that term of patients feeling that ME is a more appropriate term. And we'll go back and we'll talk about that controversy a little bit more. The important thing is that that first effort ended up with the decision that 8 of 11 minor symptoms needed to occur for a person to have a diagnosis. And I can see in yellow, this particular one, prolonged 24 hours or greater generalized fatigue after levels of exercise. Well, that's post-exertional malaise. So what you'll see is that particular symptom comes up again and again and again. The problem with this particular case definition when it came out in the early 1990s was that a number of investigators, including Caton and Russo and others, kind of felt that by requiring 8 or more minor symptoms, you could select individuals with a psychiatric problem, somatization, for example. Next slide. In part to deal with that criticism, in 1994, Fukuda came up with actually the most widely used case definition for ME/CFS around the world. And it's called the CFS Criteria. And this particular case definition required 8 symptoms. It was called polythetic. So that means 8 symptoms were listed, and you needed to just get 4 of them. But by just getting 4 of them, that produced a problem, because the 3 that are in yellow at the end, the bottom of this slide, are all very critical domains. And if you basically don't count, for example, post-exertional malaise, you might get patients who have very different characteristics. Next slide. And in a study that our group did a couple of years ago, we looked at 53 studies that used the Fukuda criteria on these 3 critical symptoms. And we found that from 25 to 100% actually counted post-exertional malaise. And with neurocognitive deficits, cognitive impairment, the rates went from 16 to 100%. So you can see that there was tremendous variability, and getting these core symptoms was not something that the studies have been doing. So in a sense, what we're probably getting is a broad category as opposed to a narrow one in this CFS entity. Next slide. The other issue about prevalence is that because the Fukuda criteria is somewhat broad and was probably implemented or used differently and identifying different symptoms at different settings, the prevalence rates vary from this period of time from 2003, around 1999 to 2007, where you've got almost a 10 percentage point from 0.24% of having CFS to 2.6% having CFS. So you can see that that suggests that the ways in which we operationalize those criteria did seem to vary. And that's what a broad criteria sometimes will do. Next slide. The other concern that some people have had with this particular Fukuda criteria is that a person with a major depressive disorder could be diagnosed with CFS, because a major depressive disorder often involves chronic fatigue and 4 minor symptoms. And as you can see, unrefreshing sleep, joint pain and muscle pain, impairment in concentration could occur where a person could have a solely depressive disorder and not CFS. And if that occurred, you begin to have much more variance in the particular sample that you have. Next slide. And the reason this is important is because mood disorders are the most prevalent psychiatric disorders after anxiety. And major depressive episode, 1-month prevalence is actually 2.2%. And it's interesting that that is so close to some of the CFS estimates of 2.5 and 2.6 that we've seen. Next slide. To deal with some of these problems, we have what's called the Canadian consensus criteria. They were developed by some expert clinicians and scientists, and they addressed the problem of a lack of identification of core symptoms. And they did require specific symptoms such as post-exertional malaise. Next slide. And you can see from this particular slide that we see fatigue, post-exertional malaise, unrefreshing sleep, pain, 2 or more cognitive manifestations, and then at least 1 symptom from 2 of the categories below. So the good thing about this criteria is that they did say you have to have some of these core symptoms. One of the difficulties with the criteria is that they do require a lot of symptoms. That's 8 symptoms, which gets back to some of the issues that we experienced with the Holmes criteria. Next slide. A little bit later, we have another case definition that came about, and that's called the International Consensus Criteria for ME. And here we have basically another 8 symptoms within these 4 general areas. And one of the areas is really post-exertional neuroimmune exhaustion, which is very similar to post-exertional malaise. So we can see that post-exertional malaise comes up again and again and again, as does unrefreshing sleep, as does cognitive impairment. We see these coming up throughout all the case definitions. Next slide. So over a 20-year period of time, there have been factor analytic studies, latent class analysis studies, cluster analysis studies, artificial neural networks, network analyses. These studies all built on, from an empirical point of view, the case studies to try to say, was there merit? Was there usefulness in them? What were the key symptoms? So we're all getting back to the issue of what are the key symptoms? And we're using not just consensus case definitions, but we're using some very sophisticated empirical methods. And there was a consistency in these different studies that seemed to point to several key symptoms. Very interesting. They're the same symptoms that Ramsey came up with 35 years ago. Next slide. So in 2015, very major development occurred with the Institute of Medicine coming up with new criteria, and they recommended 4 symptoms. And these are the 4 symptoms. Most of you probably are aware of them. Substantial reduction or impairment in the ability to engage in pre-illness levels, occupational, educational, social, personal activities, post-exertional malaise, unrefreshing sleep, and at least one of the 2 following symptoms, cognitive impairment or orthostatic intolerance. And I might add that the IOM criteria did have a 6-month period of time, but the MEICC is really the only criteria that does not require 6 months. So that is something to keep in mind as we think about the evolution of these criteria. Next slide. So I think what the IOM did, which was very useful, was that they got fewer domains, which reduced problems in some of the studies with 8 or more symptoms. But the difficulty, I think, is that this is a clinical case definition. It's still somewhat broad, particularly if you don't have many exclusionary illnesses. If, however, you exclude things that could be causing the fatigue based on other conditions, then I think this actually isn't a bad criteria. So it could be used for clinical and research purposes. Next slide. The second important issue is that besides identifying key symptoms, one needs to use validated questionnaires. And why is that? Why is that so important? That's important in any scientific area. It's important to provide operationally explicit, objectively debatable criteria to elicit the necessary information from a clinical interview to reliably diagnose a condition. So in other words, structured questionnaires make it very sure that clinicians or scientists in different settings collect interviews to maximize the accuracy of clinical diagnosis, to ask the same questions in different settings. Absolutely essential for our research purposes. Next slide. In addition to standardized questionnaires, that operationalize specific symptoms. The third area that's very important is to determine whether or not a particular symptom is severe or frequent enough to meet criteria. So I'll be talking a lot about severity and frequency, and I'm going to use the word fatigue. Now, it's interesting that the MEICC does not use fatigue, which is, again, another advantage of that particular criteria. But particularly with PASC, if you look at the studies, fatigue is probably the primary symptom that we see in multiple studies. So I'm going to talk about fatigue here, and fatigue that is severe but occurs very infrequently. Like you run a marathon, you feel fatigued, but it shouldn't be counted for something that's very low level. And if the fatigue is daily, but it's really not a big deal, you have a pain in your foot, but you can live with it and it's not really having any debilitating consequences. That type of fatigue is also, something that basically might not be something you really need to think of as a threshold being met. So fatigue of severity and frequency, it's just so important to differentiate those two domains. I'm going to try to make that point because truthfully, it has not been made in just about any of the questionnaires that have been developed. Next slide. So almost all questionnaires are based on yes/no occurrence. And that's what happened with the Fukuda criteria from 1994. The first questionnaires I developed over 25 years ago were yes/no, because that's what the Fukuda had, 1994. But the problem is these symptoms are so common that they might not be impactful at low levels. And as I've looked over COVID-19 questionnaires, they almost all focus on symptoms of occurrence, which gets us back to what happened a couple of decades ago with the ME/CFS field. Next slide. So here's some example of some occurrence items on COVID-19 questionnaires: weakness in arms or legs, pain, shortness of breath, problems with teeth. There's nothing wrong with these symptoms, particularly if we decide they're core, but the key issue is what is their frequency and severity? And that's not measured. Next slide. So let's go back to our example of fatigue. Fatigue affects at any one time 25% of the population. But in a sense, the key question is, if you ask for the occurrence of fatigue, 1 out of 5 people is going to say they're fatigued that day. But let's go even stretch it further. If you ask in surveys, have you been fatigued over the last 6 months, and you miss severity, you don't differentiate critical issues in the assessment process. Let me go to the next slide. So here are 3 groups, and I'll try to show. Here's an ME/CFS group. Here's a major depressive disorder group, MDD. Here's a control group. And if you ask these groups, this is actually real data, how did you report fatigue for 6 months or longer? You will find the major depressive group and the ME/CFS group, there's no significant differences. They're close to 90% or higher that they report fatigue for 6 months or longer. So just by asking, in a sense, for a period of time, frequency doesn't get you the differentiation. Next slide. But if you ask over the last 6 months, which is frequency, and you ask the severity, you basically then get these individuals are saying it's more severe on a 100-point scale. So the ME/CFS group can be differentiated from the MDD group, major depressive group, if you add severity in addition to frequency. But if you just ask frequency, you don't get it. And our group has been able to look at major depressive disorders alone group and an ME/CFS group in 100% differentiation of these two conditions if you ask the right questions. But if you don't, you're going to get all types of overlap. Next slide. So we, about 12 years ago, developed this Depaul Symptom Questionnaire, which had been in development for about 7 years before that. And this questionnaire assesses frequency and severity of 54 symptoms, and it's critical to specify and operationalize thresholds. So I'll talk a little bit about that. This questionnaire has been used in 22 published studies outside of our group and has data collection from people in US, Canada, Mexico, Asia, the Middle East, and Europe, Great Britain, and Ireland, and South Africa. So it's got that kind of sense that people find it useful, which is always good. Next slide. So take a look at this questionnaire. These are the frequency and severity items, and it's on a 0 to 4 scale, with 0 meaning frequency none of the time, severity, symptom not present. And then it goes 1, 2, 3, 4 until frequency all of the time and severity very severe. So in a sense, frequency and severity go up the chain from 1, 2, 3, 4, and you get a particular mark for frequency and severity. Now let's take a look at what happens. Next slide. If you basically get this threshold wrong, and you basically say, we only care about a little of the time or mild, which is a 1, versus, and then everything else. And you include all those people, and the group that doesn't get counted are the ones that have none of the time frequency or symptom not present. That discrimination is not going to get you good because these symptoms are so common. Next slide. So here's again an actual data set. And if you look all the way on the far left, I know there's a lot of data here. This is fatigue. Let's just go back to fatigue. The dark line that's blue is healthy controls. 55% would have a 1-1, meaning that it's mild or little, okay? But 100% of the ME CFS, the light blue, would say that. But you see, if you have something that you've got so many of the controls, healthy controls saying yes, then that's not helping you with discriminating. That's why you need the frequency and severity. Next slide. But you've got to have a threshold for the frequency and severity. And 33.7% of controls would meet this particular criteria. Next slide. Now, what if you basically said a 2, about half the time, frequency and severity, basically moderate? If you made it 2, 3, or 4, and you said, let's take all the people with higher than 2 or higher for frequency and severity, let's take a look what happens to the data. Next slide. You can see you get the separation. In fatigue, you get very few healthy people say yes, but almost 96, most of the people with the ME CFS group do say yes. So again, and with all the other symptoms, you can see similar types of discrimination. Next slide. So let's think a little bit about the implications of this. And I'm going to be saying some things that might be a little bit radical for some folks, but I think it makes sense to me, and at least where the data leads us to. About 25%, 15%, depending on what survey, seem to have fatigue in the general population, but only about 8% have it for 1 or more months, which is what's called prolonged fatigue. But 4 to 5% of the population has 6 or more months of fatigue. The question that the ME and CFS researchers have struggled with for decades is, how do we divide this group up? And truthfully, the best data suggests that about half of them, about 2%, just have chronic fatigue. And there's a variety of reasons for that chronic fatigue. It could be they're working 3 jobs. It could be that, in a sense, they just had an operation, that they had a medical issue. It could be that they have melancholic depression. There's lots of reasons, but about 2% have that. In addition, about 2% have a broad criteria that we might call CFS or even ME CFS. And that's about another important group, and these are the group that basically probably meets the Fukuda criteria. And then there's a group out here that has a more narrow set of criteria, and that might be the CCC, the Canadian Consensus Criteria. That could be the MEICC case definition, or it could be the IOM with restrictions that have been used with the other case definitions. And when you do that, you get a slightly different group of individuals, but important for research purposes. Next slide. So let me talk a little bit about some of the benefits our group at Depaul has gotten in trying to differentiate case definitions. So if we have a case definition that basically is more limited and specific and has to have like post-exertional malaise, which all those case definitions I mentioned do, versus those that don't require it. For example, like the Fukuda, do not require the key symptoms like post-exertional malaise. And you compare them to healthy controls. These are some results that we have published in the last year that suggest the benefits of this type of distinction. For example, in a pediatric sample, we had a saliva marker of fatigue with concentrations of 2 peptide fragments that differentiated the group that basically had the narrow case definition versus controls. Those were the only 2 that got differentiated with this particular marker. With again, a marker that's more limited, that's restrictive, we were able to find more dense interconnected cytokine networks at least 6 weeks prior to the onset of infectious mononucleosis for those who went on to develop ME. Very interesting. We didn't get the same pattern for the broad criteria. We also just published a paper where we found more gastrointestinal distress and autonomic symptoms, along with several immune markers. Again, when we differentiated the more specific narrow case definition versus the definition that's more broad. And finally, in a paper that I hope to be presenting at a conference, if it gets accepted. So this is, we're working with metabolite differences in a sample where we've been actually able to make a 97% accuracy distinction between the group that's what we think of as specific or focused case definition, we might call it ME, versus healthy controls. And that was with data prior to a precipitant event, like getting mono. Next slide. So I'm going to, in my last few minutes before we open things up, kind of propose something that can be learned from these 35 years of research in the ME/CFS area that could be useful for the PASC kind of work that's currently going on. And we think that the parameters I'm going to mention could be used to easily classify patients, and it could provide scientists with needed research case definitions for classification purposes. Next slide. So in these 5-axis, very simple system, axis 1 would involve designating the COVID variant and how it got documented, whether it's an antibody test or whatever. That would be axis 1. Next slide. The second slide would basically involve the time elapsed since infection. There are many classifications. By the way, I didn't mention this, but in 2 years of this pandemic, there's been as many classification systems as in the 35 years in ME/CFS area. And time periods has been one of the areas that's different than almost every classification that I've seen. Some say you have to, it's 5 months after, the initial infection, and it has to be for 3 months. It's all over the place. I say keep it simple. Basically indicate the amount of time that's elapsed since being infected or becoming sick. And axis 2 implies that anyone with persisting symptoms beyond 2 weeks would be classified as PASC. Next slide. So axis 3 would involve the type of collateral damage done in different organ systems. And again, it could be in respiratory, nervous system, whichever the system is. And ultimately, there will be two types of PASC. Those that have this type of biological organ documentation, or something that happened in an emergency room or in ventilators that could cause damage. But there will also be those who the organ damage is not determined. And that particular group where the organ damage is not determined probably is the group where you're going to have potentially classification of people who are, meet the case definitions of either the broad or the more narrow case definitions of ME or CFS. Next slide. Axis 4 involves a very simple system. One item, we've tried it with several different one items, where you can basically separate people into mild, moderate, or severe. And the mild people, and there's going to be people who have some of these PASC symptoms that are just not detrimental to their functioning, but they're so mild, they persist. There's going to be those who have more moderate. They're able to get out of the house and do things, but might be, they're not able to work full time anymore. So it's moderate. And then the severe ones are really more likely the folks who are homebound. And what we find is that, in a sense, that particular group, the more severe group, which again can be rated on a very simple scale, that's where we find most of the people who end up with a CFS or ME, a broad or narrow case definition. And the rates are up to almost 80% of those folks. So not everyone, but a very high percentage of them. Next slide. Finally, axis 5. This might be the most controversial. As with the Depaul Symptom Questionnaire, we think it's useful to document frequency and severity. Almost all COVID classification systems do not make this differentiation on the frequency and severity of symptoms. And by not doing that, they're going back to the same problems of occurrence that happened in the 1990s in the ME/CFS arena. In addition, it's critical to use psychometrically sound questionnaires so that it's more likely that the symptoms will be elicited similarly by different investigators. If you have everyone using different questionnaires, you have that problem of interpreting and comparing the data. So there's a tremendous benefit. And some of you know that data collection internationally, to the extent we can consolidate some of what we've learned, will be extremely helpful going forward. Next slide. We've done a recent study with COVID-19, and what we found was that in the different domains, the neurocognitive items from the first couple weeks of the symptom to 6 weeks later were the ones that actually got worse for those with long COVID. But the symptoms that got worse, if we compared them with the cohort from the ME or CFS cohort that we had, the ME and CFS cohorts were more significantly impaired. That's another interesting thing that I think it would be very welcome to have as a comparison group, the ability to actually look at ME and CFS. And by the way, for those of you who maybe aren't familiar, one of the main differences between the COVID pandemic and ME and CFS is that the COVID pandemic has a precipitating event, getting this particular virus. The ME/CFS group, ME and CFS, have different types of triggers, but it's still critically important. Post-viral illnesses are critically important for us to understand, and whatever the trigger is, that's incredibly useful for medicine, because you need to all remember that if you look at primary care, fatigue and pain are some of the primary symptoms that people come in with issues with, and we're not very good at basically dealing with those particular symptoms. So if we can learn something from our ME and CFS, as well as our long haulers, will have tremendous implications for medicine, in my humble opinion. Next slide. So the last thing about the 5-axis system is that I do think it's useful to use the criteria that have been developed in the ME and CFS field and classify people as either broadly CFS or ME CFS, or more narrowly as ME, and use the case definitions that are available. And I might add, one of the advantages of the questionnaire that we've been working on, the Depaul Symptom Questionnaire, is after filling it out, one can actually see whether a person meets which of the case definitions, and then decide kind of how one wants to use that data. Next slide. So this is going to sound a little bit technical, so but I think this is really what I'm talking about. What is criterion variance? It involves differences in the formal inclusion and exclusion criteria used by clinicians or scientists to classify patients' data into diagnostic categories. Criterion variance accounts for the largest source of diagnostic unreliability. And you don't want unreliability when you're trying to identify patients that are comparable in different labs. Criterion variance is most likely to occur when operationally explicit criteria do not exist for diagnostic categories, or when there are variant criteria for contrasting case definitions. And I might add that the only field that I've seen that has more case definitions than the ME and CFS one seems to be in the PASC one, where every time I read an article, it seems there's a new case definition that's been proposed. When diagnostic categories lack reliability and accuracy, the validity, which is the usefulness of a diagnostic category, is limited. And that's the problem with criterion variance that I think has plagued some of the past case definitions that have been proposed. Next slide. So the critical task for any illness, regardless of what you're studying, is you've got to decide on which symptoms are contained in a case definition. You've got to develop valid instruments to reliably assess agreed upon symptoms. And 3, you need to specify thresholds regarding whether or not a particular symptom is severe and frequent enough to meet criteria. Next slide. So in conclusion, and I can't believe it, I've gone right to 40 minutes. So it worked out very nicely because we wanted to end with 40 minutes of presentation. I do think that we need to reach a consensus on a case definition that involves the timing, that involves the symptoms, that involves even the name. And we can learn, because similar issues have occurred for 35 years in the ME and CFS field. And just in closing, I wanted to mention that we have a new questionnaire we've just developed at Depaul to measure PASC symptoms. And we are going to be releasing it probably in the next couple of days. So just to let you know, if folks are interested in seeing the work that we're doing. And we're particularly interested in comparing PASC with individuals who might be eligible for an ME or CFS case definition. Thank you.
Thank you, Dr. Jason. Okay, we're now going to entertain some of the questions that have been put in the chat. We have quite a few of them, but people should still feel like they can ask questions if they have something they'd like to know. So, okay, can you discuss the importance of the difference between calling a disease chronic fatigue versus chronic fatigue syndrome versus ME/CFS versus ME?
Well, thank you. That's an excellent question. In the physiotherapy field, an article recently was published that basically used the terms CF for chronic fatigue, ME for myalgic encephalitis, and CFS for chronic fatigue syndrome. And what they did was they said, well, if you're going to use ME, you have to require post-exertional malaise. I would have said require 3 domains. They said 1 domain. I think all 3 domains need to be in there for an ME's criteria. And I think that goes back all the way to Ramsey, if you want to look at his work. But even if you get PEM, you're going to basically get individuals with what we could think of as maybe a different type of illness, something called myalgic encephalitis, which is the original name that was given to this illness many years ago. However, there's some criteria that are broader. And what these authors said was that they don't require PEM, but you might have it as a polythetic criteria. In other words, you pick 4 out of 8, and it might get picked as one of the 4. To the extent that you basically use that type system, you're going to get more variability. And as I suggested, when we looked at the Fukuda criteria and looked at PEM, we saw some articles had it, some articles did not have PEM in it. And that's the problem, variability. It's a broad case definition. So what they said was use chronic fatigue syndrome for those studies. And then the controls are the ones who basically, don't have it. And again, controls could be all different types of controls. But if you take that 3-category system, what they found, which is really fascinating, and again, we've been kind of talking about this distinction for at least the last 10 years, that if you look at physiotherapy treatments that might be effective for people with CFS, which doesn't require those symptoms, there's no evidence that those treatments are effective for the ME group. As a matter of fact, they suggested that applying it to the ME group could have unbelievable negative consequences because there's no evidence that they're effective. So I think that a distinction between those who have these different types of symptom complexes has usefulness. And we'll just kind of think of it this way. You've got a broad criteria, and then you have a more narrow criteria. They both are important to understand and study, but differentiating them, at least in our lab, has allowed us to find more biological, physiological differences between the controls and the patient group. Then we basically collapse them.
Okay. Somebody asked about a link to the Depaul system questionnaire, and we can include that in the email that we send out following this presentation, that will have a link to the presentation.
So Art, just to mention real quickly, on our website, if you put in leonardjason.com, we have all our questionnaires are listed on our website, as well as in different languages that they've been translated into. Our DSQ-1 was developed 12 years ago, and it's, as I said, the most frequent one. We have a data set of over 2,500 patients that have completed that just within our own setting, but it's been used by 22 different investigators around the world. So that's nice, kind of, it's called face validity. But we also have a questionnaire that's called the DSQ-2 that brought in some additional items that was not on DSQ-1. That one is also posted. It's a little bit longer. So the DSQ-1 has 54 items. We added about some other areas that were important that are in DSQ-2. We also developed the DSQ short form, which is just 14 items. And we validated it. And actually, it can also be a great screener and can identify individuals who might have the particular case definition. So the DSQ short form is available as well. And we also have a DSQ PEM, which is 10 items from our questionnaire. And we also have a DSQ much more comprehensive for those people that might have PEM, post-exertional malaise symptoms. So these are the ones. We also have questionnaires for pediatric samples for both the child and the parent. So these things are all developed. They're all free. They're all available. They all have algorithms so that you can use them to develop whether they meet a case definition or not. So we continue to work on these things, and we're ready to launch our next questionnaire because we do think that COVID has some unique symptoms, and we want to comprehensively evaluate it. And we'll be releasing our Depaul Symptom Questionnaire COVID in the next couple of days. And that we'll also release it with it, a short form of our DSQ as well as the DSQ PEM, so that we can, in a sense, be able to see how it's related to these other, we're interested in how certainly PASC is related to ME and CFS.
Okay. All right. Do you have any suggestions or ideas on advocacy / awareness / social causes for PASC in terms of whether they should be included in the ME CFS umbrella, or do you believe the advocacy awareness groups should be separate for PASC and ME CFS advocacy?
So I'm not sure I caught the entire question. I had some slides coming up that I was reading as you were talking. But let me say that I think that the folks who have been affected with COVID are such a large group. If it turns out, some of the estimates might be 10% continue to have symptoms, that would be an incredible number of people. We've estimated that there might be like 1.5 million people with ME and CFS. Well, this new group is going to be much larger that has symptoms, of which some of them will be ME CFS. Now, as I mentioned, those who have mild or moderate PASC, most of them are not going to be classified as ME or CFS. So there's going to be a lot of people who have symptoms. It's just not ME or CFS. But I do think that there's critical information that we as scientists can learn from both groups. And really we're at the early days as to what we're learning, what might be causing these conditions. And the good thing is there are literally hundreds of top-notch scientists around the world who are studying these phenomena. And in the US, we have a very, very large trial that's occurring. Over 17,000 people are going to be followed. So these are incredible opportunities that we can take advantage of and basically expand the knowledge base. But I do believe that the knowledge base has a better chance of expanding if we can learn the lessons that have occurred for the last 3.5 decades in the ME and CFS arenas.
Okay, thank you. Next, if PASC has physical changes, how is it comparable with ME CFS?
So there are physical changes that occur in PASC, certainly from initially the first couple of weeks to 6 months later. There's lots of changes that occur. in terms of symptomatology. But that's not any different from what we see in, ME and CFS samples. When you see them over time, there's also manifestations of the illness that change. Matter of fact, some people have even kind of, talked about trying to capture the experience of even different days when there's more and more impairment or less impairment. So there's some very interesting research that's tried to do that. But I would say that while overall there's a sense of people having impairment, that level of impairment does fluctuate quite a lot for people in the ME/CFS arena and many people in the past condition as well.
Okay. On the IOM case definition, for ME/CFS, how can those symptoms like, substantial reduction in impairment for 6 months, PEM, cognitive dysfunction, deficits and unrefreshing sleep, how would those symptoms, how would you actually differentiate ME/CFS from diseases like cancer, MS, myasthenia gravis, and other chronic diseases? In other words, are these, I guess what the person is asking is how unique are these symptoms really to ME/CFS? And is the IOM case definition possibly too broad?
Well, I do think that, there's a clinical versus a research criteria. And as I said, the clinical criteria might be broader and the research criteria might be narrower. I think that's kind of a helpful thing for the field to think about. But, just think about substantial reduction in functioning. That's pretty interesting. If you have cancer or you have tuberculosis, they don't ask you whether you've had a substantial reduction in functioning. They say you've got cancer, you got tuberculosis, you've got a diagnosis. If you think about where substantial reduction came in, you've got to look at the Diagnostic and Statistical Manual. That basically is the Manual of Psychiatric Illnesses. That's where that particular notion came in. So they want you to say you really have something very different from normal. It's a controversial issue, but if you want to measure it, and because the case definitions do require that, so I say if the case definitions require it, we should measure it. We at Depaul have for over 20 years been using the MOS, or the short form of medical outcome survey. Some of you might know it by different terms. It's somewhat of a long questionnaire, but we spent study after study trying to come up with different criteria to determine what does it mean to have. You think substantial reduction in functioning is easy to nail. It's not. I think we published 10 articles trying to figure out what that means. And I'm just saying that some of these things that everyone takes for granted as being relatively easy to operationalize is not. But the fascinating thing, we have these very sophisticated formulas, very complex questionnaires, the SF-36, for example. And we found that one item on the DSQ was as good as all those items in measuring in samples with ME and CFS substantial reduction in functioning. And what's that item? Have you had a 50% reduction in functioning? If you say yes to that, you meet the criteria for all the different ways we've tried to operationalize that entity. It's fascinating. So we haven't actually published that paper yet. We're in the process of trying to. But what that shows is that we always have to work toward trying to do things in the easiest way that has less burden to our patients and our people that we're working with.
Okay, next, I'm combining two questions, so this will be about 3 sentences. Historically, women have been more likely to have been stigmatized and associated with hysteria. Do you feel that is the case with long COVID? And has there been a change in attitude as people learn more about the condition? And also, are there any comments that you might be able to make having to do with differences in sequela, for example, between long COVID men and women?
Well, we have a brief program here, and those are some pretty tough questions to get into. So let me just briefly say that there's a lot of illnesses, autoimmune illnesses, where women have higher rates than men. So the fact that it occurs with ME and CFS, should not surprise us. And there are potential biological reasons for this, but I'm not going to get into them right now. I think the key thing to remember is that there are many patients who are legitimately dealing with a very burdensome and stigmatizing illness. And why is it that? If you are a person who basically is kind of looks okay and goes to your doctor, and you basically say you have something that they can't find a test to basically document that you have it, like you would with, for example, cancer, you get into this nebulous area where people start wondering, do you really have a illness, or is it something that you basically are, catastrophically sort of imagining for minor symptoms? And because primary care deals with so many individuals who have lifestyle reasons for their fatigue, it's very easy for people to assume that patients that are coming in are comparable. And for example, just exercise or just take some antidepressants and you'll be okay. And those treatments are generally not going to be what people with ME are requiring, or any of the data Kenneth would support. So I do think that there is a tremendous educational effort that needs to continue, that our government is trying to work on, patient organizations are working on, to try to help people understand the significance of individual and treating everyone honorably, and trying not to victimize the person a second time. They've been victimized by having a significant illness that's incredibly incapacitating. We don't want them to be victimized a second time by the societal response to their condition.
Okay. Have neurophysiology studies proven helpful in diagnosis, specifically nerve conduction studies, which is electromyography, measurable and objective?
So there is exciting research going on with fMRIs, MRIs, quantitative EEG, and there are a number of studies both in the ME and CFS field as well as the PASC field that suggest that there might be some dysregulations. In a sense, really the way to get that is one needs to be thinking about systems. And I think when we look at networks and how, in a sense, different sites in the brain are communicating or not communicating, we have a better chance of finding out where the dysregulation has occurred. And I am of the field that tends to think that a lot of these answers are going to be in the brain. And I know that other folks, look to different systems in the body, but I do think what we are going to learn from some of that research, and actually some of the research, we're doing in that area in Chicago. So we're very optimistic that we're going to learn a tremendous amount about the brain from these studies that are occurring and will occur into the future.
Okay, in your opinion, is post-exertional malaise or post-exertional fatigue, as confirmed by the Depaul Questionnaire, specific to ME CFS?
So, yeah,
how specific is it to ME/CFS, that is, I guess, and might it really also be an indication of some other disease?
Yeah, I mean, there are some other conditions where you do have this phenomenon called post-exertional malaise, but they're not many. And I do think that when you look at the caricature of the particular illness in terms of what happens, so for example, if you tell a person, like, it doesn't occur exactly at the time of exertion, but it might be several hours later or even longer, that's very unique kind of stamp. So post-exertional malaise is a fascinating entity in terms of the things that can trigger it and what responses get triggered. And I think that it's just a neglected area right now of research because it's so unusual. And I do think that it is the key for understanding many of the things that are going on. Because when one experiences post-exertional malaise, I think it has implications for sleep, and I think it has implications for cognitive impairment. So I think these things are all wrapped up together. Yeah, I mean, I think it's very, very exciting kind of work that's going on.
Okay, so I'm going to ask two more questions, and then I think we'll wrap it up. So can the energy envelope, like comparing good days and bad days for people with ME/CFS, how well can you actually differentiate ME/CFS, say, from major depressive disorder, based on the energy envelope?
Okay, so we've actually done some good amount of research with major depressive disorder and ME and CFS. And the interesting thing is you can really make differentiations between a solely psychiatric condition versus ME and CFS if you basically use the right tools. If you don't use the right tools, you will have a blurring of these two conditions because there's so many symptoms in common. So let me give you a non-technical appreciation of what we're talking about. If you asked a person with major depressive disorder, if you were well tomorrow, what would you do? They would basically say, I don't know. If you asked a person with ME or CFS, if you were well tomorrow, what would you do? They'll start making a list of you, okay? Anhedonia, self-reproach is so different. It doesn't occur in the ME and CFS, but it's one of the classic symptoms in major depressive disorder. And this is why it's so important. If you have a major depressive disorder and your physician says, why don't you work out? Why don't you, do some more walking? Why don't you even go to kind of an exercise class a couple of times a week? Those things are actually state of the science. That is what is empirically validated for major depressive disorder. But if you use those techniques with someone with the classic case of ME, what you can ultimately do is impair that person's effort at staying within the energy envelope, which we call it. And the energy envelope says that you have a certain number of perceived energy and you have expended energy. And how can you keep that somewhere sort of equivalent? So your available energy might be 40 now and it was 100 when you were healthy. Well, if your perceived energy is 40 and your expended energy is 60 or 70, well, you're going to be exhausting that battery. And what you have to do is let that battery slowly recharge by staying close to what the acceptable limits are. That's what pacing is. That's what staying within the energy envelope is. And I think that ultimately there will be more research that will be conducted that will show this to be one of the most effective things that patients use now and could be extended to many people in the PASS community.
Okay, is can you say something more about how one measures cognitive dysfunction? Is it typically done in surveys? Are there objective measurements that assist in the diagnosis and case management?
So, cognitive problems, impairment, there's different ways of getting at it. If you want to go to someone like Gudrun Lang, she could basically give a very detailed battery of tests to kind of measure all types of domains to basically come up with a score to show that, your cognitive impairment is. A simpler way of doing it, if you don't want to go through the expense or don't have access to someone as talented as she is, you could, on a questionnaire, ask 4 or 5 items that basically capture kind of what happens when people kind of, get in their car, drive somewhere, and then forget where they're going because they can't remember. Or 100 other things that happen. You can tap those domains of behavior by good self-report questions that can basically document whether you have those symptoms at least half the time at moderate severity. And if that's the case, then you say that's a problem. And we have used things called machine tools. It's actually something called artificial intelligence to come up with ways of developing and assessing what criteria hit threshold. And our machine learning strategies, and we work with the computer science person at Depaul and his students to help us test that out, has come out with a 2-2 as basically the criterion, the threshold that makes a difference. And that is at least half the time in moderate severity. And we have actually evidence. So the things that we're saying are not basically just something we've sat back in a chair and said, this makes sense. We've tested out everything in the laboratory to try to find out, is there evidence to basically support what we're basically suggesting.
Thank you. I'm going to sneak one more question in. This will be the last one that I think people who are interested in health equity would be very curious, given the kind of studies you've been doing. So many of your studies have been done in an urban area. Are there particular procedures you use to better reach out to and sample disadvantaged populations?
Well, when you say disadvantaged populations, I'm in Chicago. And for any of you who have been to Chicago, Chicago has quite a few disadvantaged communities. And they're on the south and the west side. And we have a very diverse population of individuals. And I might add that in our adult epidemiology studies, which were done from 1995 to 97, where we collected our data, in our pediatric comparable epidemiology study with pediatric samples, we surveyed thousands and thousands of people randomly, and we brought them in for not just medical tests, but we also had psychiatry tests. So we looked at the psychology and the body. It wasn't just one thing. And we have blood samples as well. And that's what we're doing some of our biological work with now. But the reason I kind of mention it is that our samples are socioeconomically diverse, ethnically diverse. So, and we have found in our community-based studies that actually African Americans and Latinos have actually pretty high rates, as opposed to most of the studies that have been done in tertiary care centers where you don't see those samples of that ethnicity. So I would say Urban areas can have quite diversity if you have the right particular tools, which involve community-based epidemiology, which our group has been working on for many years. And we believe in that. We also believe in prospective longitudinal studies, where you try to get people before they got a precipitating event. Those two research designs, I think, are the gold standard, not just with this particular illness, but with any illness.
Okay, well, look, I'd like to thank you very much, Dr. Jason, for this very informative and interesting presentation. We will be posting the recording of this presentation in a few days at the link shown on the screen for those of you who are watching it. That's at usawg.wordpress.com/news. Information on how to view the recording will be emailed to each of you and will also be available on the USAWG website. And thank you all very much for coming.